All right, can you guys see the PowerPoint?
Yeah.
Okay. All right, so pediatric emergencies. See developmental characteristics of the infants. So here are some numbers that you guys want to know. So newborns and infants from birth to 1 year. Toddlers would be from 1 year to 3 years, and preschool age are 3 to 5 years. The one that's not on here that I think you guys should also write down if you are going to write these down is neonate. And neonate is a newborn from birth to 1 month, but it also falls in this category as well. And I will give you guys a sec in case you guys want to write this down. All right, I think that should be enough time. All right, recommended not to rely on memory for recollection of normal vital signs. So a lot of these kids from baby up to being around high school age, their vital signs vary a lot. So it's really smart to have a little cheat sheet so that you can reference every time you are dealing with the pediatric. So that's a good little note. So write everything down. Or I know they sell templates, or they actually sell little memory cards with vital signs on them as well. So that's an option. Infants and children differ from adults in psychology, anatomy, and physiology. So psychology, obviously, in the way they carry themselves, they register information. Anatomy is in proportion. So in proportion, we are very different, and we are gonna go over some of those differences. I mean, we already did go over those differences, but this chapter is more of a review. But we're still gonna go over it. So, and the physiology as well. Physiology has to do with the amount of blood volume they have in proportion to the mass. So the organs, the vessels, in relation to the blood volume itself. So that's where the physiology really comes into play, aside from other things. So understanding differences will help you assess and care for the young patient. See, infant, child supine, the head. So I did talk about this little note here. It says when an infant or young child is supine, so this is supine, he's laying down looking up, the head will tilt forward, obstructing the airway. So that's because the occipital portion of the head, the occipital part is the back part right here that I'm pointing to. That, in proportion to us, tends to be bigger in children. So because it is bigger and it sticks out more posteriorly, it's going to tilt the head forward, how it shows here. So one thing we do to fix this is we pad underneath the shoulders. So we can get a towel or a blanket folded up and make it to where the padding is going to align the kid's airway. See, proportionally, so the head proportionally larger and heavier than an adult until about age 4. That's a good little note to have, just to know. Always suspect injury if serious mechanism of injury. Now remember, the mechanism of injury, MOI, is the picture of what happened. So as you're approaching the patient, what you see is the mechanism of injury. You're looking at what is laid out in front of you to get an idea of how the patient got hurt. Let's see. Fontanus soft spot at the top of the infant's head. I actually found a video on this. It's pretty decent, so I'm going to share it with you guys right now. Okay, here we go.
All right, guys, so we just finished the adult skull. So now what we're going to do is we're going to go ahead and get into the fetal skull. All right, so what we're going to do in this video, we're going to talk about the fontanelles. So if you look here, fontanelles are basically just connective tissue, and they're designed to allow for the skull to expand so that the brain can, you know, take on that increasing space. So obviously any type of irregular closure of these can lead to a lot of different issues that we might talk about in future videos. All right, so if you look here, this right here, this fontanelle is going to be called the anterior fontanelle. That's called the anterior fontanelle. Then if we come over here, and I'm going to flip it in the back, here's the posterior part of the skull. So this is going to be called the posterior fontanelle. Okay, so that's the posterior fontanelle right there. Then if we flip it over here to the lateral side, over here in the back part right there, that's going to be called the mastoid fontanelle. So that's our mastoid fontanelle. And then the last fontanelle over here is going to be called the sphenoid fontanelle. Okay, so again, we got anterior fontanelle, posterior fontanelle, mastoid fontanelle, and sphenoid fontanelle.
This little light of mine.
I gotta put the volume up on my end. Did you guys hear that good? I could barely hear it on my side, but nobody spoke up, so. That was good? All right.
Too loud.
What was that?
Oh, I said it was loud. Like I could
Oh, was
hear it.
that? Okay, I could barely hear it on my side. All right, let's keep going then. Okay, talk about that. Okay, so airway and respiratory system. Mouth and nose are smaller, more easily obstructed. So mouth and nose, we're talking about the space inside, the cavity itself. The tongue takes up more space. So in proportion, the tongue is bigger than the cavity itself that it's inside. And we're talking in comparison to an adult. Typically breathe through their noses. So pediatrics tend to be nose breathers. Trachea, windpipe softer and more flexible. So this matters because when we do a head tilt chin lift on a patient, if we overdo it, there is a possibility that we're going to kink that airway and then we become the obstruction. So that's why this really matters as far as the flexibility. The fact that it's already more narrow than our airway in proportion, that matters because swelling has a bigger effect on these patients more than it does in adults, and is easily obstructed by swelling and foreign objects. Chest wall is softer. That's because obviously the muscles, the layer of muscles is going to be thinner for pediatrics, and also the ribs are going to be flexible. They're not going to be as hard or solid. So that's why. The thorax shorter and located adjacent to a very full abdominal cavity. Abdominal contents can prevent the diaphragm from dropping far enough. Give me a sec, guys. Give me a sec, right? I'll be right back. All right, sorry about that, guys. So see, abdominal content can prevent the diaphragm from dropping far enough to promote increased lung capacity. That is, yeah, it's a possibility, obviously, for children, but this is becomes more of a big deal when it comes to your bariatric patients. Now, bariatric meaning overweight, and geriatric means elderly. So with your bariatric population, because their abdomen is much larger because of the contents in it. That what happens is if your bariatric patient lays down supine, the gravity will push the contents of that stomach down and is going to push against the diaphragm. So because of that, it's going to prevent the diaphragm from contracting downward and creating enough negative pressure. Neonatal ribs are more box-like, limited ability to take deeper breaths. Because infants are nose breathers, be sure to suction secretion from the nose as needed. So suction the nose, obviously. And we talked about this last part right here. A hyperextension or flexion of the neck may result in airway obstruction. So like I said, a lot of these PowerPoints are review, but I figured pediatric would be a good review anyways. Okay, so this right here just kind of illustrates, it shows you, it gives you a better visual of what I was talking about. So the tongue for pediatrics, this is a pediatric, an adult, the tongue for a pediatric is bigger in proportion to the cavity, to the opening of the mouth. See the difference? Here we have more of a gap. So proportion, we have a bigger gap. Tongue is smaller in comparison to the mouth itself. See, chest and abdomen, less developed, more elastic in younger patients. We talked about why infants and children are abdominal breathers. So these patients tend to breathe with their diaphragm more because their intercostal muscles are not strong enough or big enough to help out in creating enough negative pressure. So the diaphragm has to pick up the slack, I guess, so to speak. And it has to just really extend downward. So that's when you'll see the babies and even toddlers sometimes where every time they're breathing, their stomach goes in and out, in and out. And that's because they breathe with their diaphragm as opposed to the intercostal muscles. And that's why we see that. Abdominal organs less protected than in adults. That's because of the muscular wall being being thinner. See, body surface larger than adults in proportion to the body mass. So all this is saying is that the container itself, so the skin is a container, there is more container than there is fluid inside or mass inside. So if the container is bigger than the content inside, the patient can lose heat a lot faster. And that's because there is more surface area on the outside for heat to escape. And that's why they are prone to be hypothermic. Hypothermic meaning that they are cold. And that's because of the surface area in comparison to the actual mass and volume inside the body. See, so less than blood volume of adults, again in proportion, so in comparison. And this is a comparison they use right here, so it's a pretty good comparison. And then if you want to write these notes down, I'll give you guys a minute because they are good little notes to have. So I'll give you guys a minute or two. All right, keep going. See, during transport, the child must be appropriately restrained. So when I was in San Diego, sometimes they would, depending on which company, they would allow the child to sit on the parent's lap and the parent would be on the stretcher. And I'm guessing that because of situations like that, that this PowerPoint exists right now. So always put the child secured by themselves on the gurney, and don't have them sit on the parent's lap. That's pretty much what this is saying. See, identify. So interacting with the pediatric patient. Identify yourself. Obviously, you want to say, hey, hi, my name is John. I'm an EMT. How are you doing? Let child know that someone has called or will call his parents if they're not there. If no life-threatening problems, continue at a calm pace during the evaluation process. See, let child have a nearby toy. I mean, that's kind of a no-brainer. If a child that you have, if a pediatric is not cooperating and kind of antsy, and they want anything, they want even a bandage or a toy, or they just point at something they want it, just go ahead and give it to them as long as it's not gonna hurt them, just to calm them down, and also it'll make your job a lot easier at the same time. That's why too. See, kneel at a child's eye level. The reason that's important is because it's more of a security thing than anything else. Give me one more second, guys. I'm sorry, I'm gonna be in and out here for a little bit. So I'm not sure if you guys remember this, but we talked about how you want to be at eye level with any pediatric, and that's because it makes them feel a little bit safer, and you're not looking down on them. If you look down on them, they can see that as being threatening. That's why it's so important. See, smile. Obviously, don't be frowning and looking mean at the kid. You don't want to do that. It's gonna scare them. Touch or hold child's hand or foot. So the reason for this, I read a little bit on this, and it's kind of to create some kind of connection with the child. It's supposed to make them feel safe, and I think that's why they always say to start at the foot whenever assessing a child's like a toddler or an infant. And the reason you start at the feet, if possible, is because it's supposed to make them feel comfortable. I forget exactly why, but it's something to do with that. Let's see. See, never lie to a child. See, let child see your face. Stop occasionally to find out if child understands you. Supporting the parents or other care providers. Let's see what it says here. Possible reactions to child's illness, injury, denial, shock, crying, screaming, anger, self-blame. So these are all things that to expect from a parent after the child has been in some kind of traumatic situation, or if they're very ill. And every parent is going to act different because it's all from upbringing and background. So you may interfere with care of child. When this happens, it's a good idea, if you can, to have them step away, or maybe have your partner kind of distract them for a little bit, where you assess the child and continue and complete care on the scene if that's necessary. See, not all children live in a traditional nuclear home or family. I'm trying to find things that actually really need to be said. As to help by holding, comforting the child. See, if at all possible, parents. So yeah, so during the actual patient assessment of a child, if the parent is actually not combative, not arguing, and still able to help out, please by all means help yourself and have them help out and kind of participate in that assessment, because if the parent's helping and they're interacting with the child through you, obviously the child's going to be more accepting of that, right? And you can get more out of the child and give better care because of that. All right, and I'm gonna go ahead and play this video for you guys.
Caring is a nurse's emotional investment in a child and his family. Through caring, a nurse offers compassion and support and responds to the unique needs of their patients. Caring evokes a feeling of security and comfort. A nurse can demonstrate caring by perceiving the child's needs and concerns while showing that the child is valued. A caring and comforting environment provide the child and the family the atmosphere needed for open communication. Empathy is the ability to perceive another person's experience from his or her point of view. Through empathy, a nurse conveys awareness of the child's feelings by understanding how that child views the situation. This differs from sympathy, when a nurse associates with the feelings of the child. Actual understanding of the child's experience from his or her point of view is empathy. This allows a nurse to choose appropriate and effective communication methods based on developmental and situational concerns.
All right, so assessing the pediatric patients. See what we have here. All right, so this is the see appearance, pediatric assessment triangle. So this is also known, it says here, so it's also known as from the doorway assessment or at the door assessment. Different textbooks call different things. But it's a real quick assessment of the child. Just by a quick glance, it should tell you how the patient is doing. So it's just like the primary assessment of a patient. So your primary assessment is primarily based off of your patient's appearance. This is very similar to that, but it's more straightforward in general. So these are the elements that pertain to the pediatric assessment and its appearance. So do they seem lively like a normal child does? So if it's a 3-year-old, most likely, if they're normal and healthy, they're gonna be running around or being very active. They're gonna be playing or something, right? So are they active? That's normal. Or are they lethargic and tired and drained? So that's what that tells you. Work of breathing, that is it adequate or inadequate? If it's adequate, obviously they're not gonna be struggling to breathe. So they're gonna be like you and I. You can barely tell they're breathing. That is adequate. If it's inadequate, you're gonna see them struggling to breathe. You're gonna see that chest retracting, that those ribs popping out. Maybe that stomach really protruding outward, the nasal flaring. You'll see all those things. Okay. Circulation to skin. So that one should be: are they pale? Are they flushed? Or do they have a normal appearance? And even it doesn't really matter what shade of color they are or what skin color they are. You can tell if a pediatric or even an adult is somewhat lethargic or in shock, because there is some kind of blotching on skin regardless of the color, and there is discoloration and it doesn't look normal, and we can all tell if someone is looking under the weather or not. So these 3 elements, if you guys do not know this, this is just a quick little PowerPoint on it. I think that we do go over it a little bit more, but please write these down, at least the elements. Also, it's known as from the door assessment. And I also have a YouTube video on this that's pretty good to watch, and I recommend you guys go back and watch that if you just find it on my links. And only because it's gonna help you out for your NREMT. I know it is. So go ahead and take a minute, write this down if you don't know it. All right. So these are triangle appearance again, a work of breathing and circulation to skin. That's what we're looking for. Scene size up and safety pediatric. Obviously maintain an open airway, care for shock. However, you need to care for shock, protect from hypothermia. We do that by putting them in a blanket, maybe putting a beanie on the child if we have to. As far as providing supplemental oxygen, the best way to do that sometimes is going to be by blow-by. And what blow-by is you're just putting the mask by the pediatric's face and allowing the air to just blow by their face, and that's exactly what it sounds like. It's just air blowing by their face. Support ventilations as needed, obviously. Let's see, okay, assessment. Forming a general impression. So rapidly identify critical patients. The PAT can be used for that, or just your regular primary assessment. See, essential component of pediatric assessment. Make the following observations: mental status, interaction with environment or others, emotional state. More things. So this is a cool little PowerPoint. It's a visual, but I like it. So for your infants, a capillary refill will be done on the hand, because obviously their fingers are too small, and when they're freshly born, also they're gonna have a tint color to them. So you take blood pressure in patients older than 3 years of age. So I would write this down because I find that a lot of people forget this, that if the child is younger than 3 years, you do not need to take a blood pressure on them, okay? See, physical exam, pediatric. See, start with toes, trunk, and work way towards the head. Again, I talked about this. This has to do with getting them to feel safe with you, and somehow by starting at the feet or the toes, psychologically, from what I read, it does something, and it makes them it makes you more familiar, or it makes them see you as less of a threat. I think it has to do with their parents playing with their toes or feet, and I think it's linked like that somehow, but I don't know. But that's what I got from what I read, at least. See, if no injuries, patient should be held in parent's lap. Protect child's modesty. So that goes without saying. Explain why each piece of clothing must be removed. So as far as explaining why each piece of clothing must be removed, that goes back to just letting the pediatric and pretty much any patient know what you're doing before you're doing and why, because you don't want to catch them off guard. That's why. And pediatric or adult, there are going to be situations where if you don't tell the patient that you're going to do something, you're going to startle the patient, and in some cases even upset them. See, the head, do not apply pressure to frontalis. You know what that is already. Meningitis and head trauma can cause bulging of fontanelles. I'm pretty sure I'm still saying that wrong. But I did find a video on meningitis that I want to share with you guys.